Good afternoon, friends. I feel very happy to present before you my friend Dr. Kilani. Currently, he is professor in the Department of ENT at Bhuj Medical College, and he has many papers to his credit, 43 publications to his credit, and he has contributed for books also, and the chapters for the books. And he will be speaking regarding this our COVID-19, specifically the ear, nose, and throat manifestations and their management. Because sometimes when the patient comes to us, it is very difficult to differentiate between the common flu and this COVID symptoms. So there are certain specific ENT symptoms. They are highly specific for this COVID. Dr. Kilani will be talking about the symptoms, and other symptoms they are not that specific for the COVID. And as you all know that ENT surgeons, they are at great risk of contracting this disease because we sit very close to the patient and we examine the patient's nose and throat and they cough. So ENT surgeons, they are at high risk. So I will request Dr. Kilani to cover the preventive aspect of this COVID specific for ENT surgeons. And then tracheostomy is a very big issue in the COVID patients. So again, I would request Dr. Kilani to cover that tracheostomy aspect also. So here I present before you my friend Dr. Kilani. Yes, Ajit, you can proceed.
Yes. Thank you very much, sir, for your kind introduction. And yes, I thank you and the Parul University for giving me this opportunity. Actually, when you called me, you just told me that whatever topic I want, I can select. But then I thought that this will be a good topic to talk on because many of us will be interested as ENT surgeons also. And otherwise, even if you're not practicing ENT, but there are some certain guidelines that we should be aware of regarding this topic. So, sir, are you able to see my screen, sir?
Yes, I can see your screen. I can see your screen and your presentation also I can see. Your slide beautifully prepared. Good color combination. And I can see, yes, I can see you also in the video.
Okay, thank you very much, sir. Okay, sir. So today I'll be talking about ENT manifestations in COVID-19. And good afternoon, everyone. Welcome, everyone. I'm Dr. Ajit Khilnani. I'm working in the Department of ENT at Gujarat Adani Institute of Medical Sciences, Bhuj. So as we all know that we are in a very unfortunate situation at present in the midst of COVID pandemic, and the ENT surgeons has a point in mind, which will help us in preventing ourselves as well also in prevention of the spread of this disease. So I'll start. My talk will be under these headings. Initially, I'll talk about some introduction, then pathophysiology, then symptomatology, then diagnosis. What are the safe practice guidelines for us as an ENT surgeon? What is the role of tracheostomy and what is the current evidence in tracheostomy? And finally, what are the recent treatment guidelines? So my talk will be around these headings. So I'll start with the introduction. Now, as we all know that the coronavirus, as it is called severe acute respiratory syndrome, coronavirus 2. Now, here we call it as 2 because a virus from the similar family. Coronavirus is a large family of RNA viruses. So a virus from the similar family also caused an epidemic way back in 2002 and 2003. And when it was called as severe acute respiratory syndrome, coronavirus. So that was again in China also. Then another virus from the same family, it also caused a epidemic by the name MERS coronavirus, that is Middle East Respiratory Syndrome coronavirus, and that was in around 2012 and 2013. That was in Saudi Arabia, that is Middle East. So this virus is this particular virus is of course a new virus, but the other viruses of this family, that is coronavirus family, they are known to cause epidemics in humans. Now, as such, it is a zoonotic disease, but because of some mutation in the virus, maybe it has somehow gained entry into the human body. So initially, it was known as 2019 novel coronavirus, but then the World Health Organization it came up with a new name, and now we call it as coronavirus disease, that is COVID-19. So on 30th January 2020, the World Health Organization informed everyone that there is a public health emergency of international concern, that is COVID. And in the subsequent months, finally it was designated as a global pandemic on March 11, 2020, as it was seen that it was not containable at that point. So on 11th March, it was confirmed as a pandemic disease. So it was first reported in the Wuhan, in the Hubei district of the China in December 2019, and hence its name COVID 2019. And then onwards, it has very rapidly it has spread globally. So if we see the latest data, so updated till yesterday, the total people who are affected in our country, India, there is around 52 lakh people have been infected with this virus. Out of those, unfortunately, we have lost around 80,000 lives. Then in world also, the numbers are very alarming. Around 30 plus million people have been affected in all over the world. So it is a very rapidly progressing disease. Now the pathophysiology of this coronavirus. So the incubation period of this coronavirus, it can be from 2 to 14 days, but average it has been put up at 5 to 6 days. So this is the most common period in which the patient can get infected. Now, if the patient is in the incubation period, then maybe he may not show the symptom, but he transmits the disease. So that is called pre-symptomatic transmission, and that is a very cause for concern, because it is this time that most of the tests which we do for the coronavirus, they come negative, but still the patient is a carrier, or he is a transmitter, or he is infecting other persons. So that is called pre-symptomatic transmission. Now the mode of entry of this coronavirus in the human body, the most common proposed is through droplet infection. Now droplets, they are of a larger diameter as compared to droplet nuclei or the airborne droplets we say. So the droplets, they are around more than 5 micrometer in diameter, and they travel a short distance, that is less than 1 meter. Because they are heavy, they just settle down. So the most common proposed method of transmission of coronavirus from human to human, it is through droplets. Now, as we see that when a patient coughs and sneezes, then he releases a large number of droplets. And these droplets can gain entry into a susceptible individual if the distance between these two individuals is short. And that is the main point, that if we may increase the distance between two individuals, that is the point for social distancing, then we can decrease the transmission of this virus. Then initially we thought that it was only the droplets that can cause the infection, but nowadays the droplet nuclei, which are still smaller particles, less than 5 micrometer in diameter, they are also known to cause the infection from one individual to another, and this type of infection, it is known as airborne infection. So these droplets, they remain suspended in air for a long time, and they also travel for they can travel for long distances. So this is again a cause of concern, the airborne transmission of this virus. Another mode of transmission, it can be direct contact or indirect contact. Direct contact means if we shake hands or if we get in contact with a person who is already infected with this virus, then that virus can gain entry into our body. That is direct contact. And that is again the reason that social distancing and avoiding contact is given so much importance. Indirect contact means an infected individual, he can touch some surfaces, for example, door handles, tables, chairs, and if a healthy individual comes and touches those things, then he can get infected, because it is known that this coronavirus, it can survive in the outside environment or on some surfaces from 24 to 48 or 72 hours rather. And that is again the point, that regular cleaning of the surfaces, regular hand washing is required so that this virus is killed. Now, as I told you that the infected individual produces droplets when he coughs and sneezes. But even if he is simply talking or whispering, then also the droplet nuclei can be generated and they can cause airborne transmission. So these are the various routes of transmission from an infected individual to a susceptible individual. The most common being droplet infection. Now, as soon as this coronavirus gains entry into the human body, it affects basically the upper and the lower respiratory tract of the body, and it incites the inflammatory cells, that is macrophages, T lymphocytes, then endothelial cells, fibroblasts, and the dendritic cells which are present in the respiratory tract. And these are excited, these inflammatory cells are excited, and they generate various inflammatory moderators in the form of cytokines and chemokines. For example, the common ones are interferons alpha, gamma, then 1 beta, interleukin 6, 12, and so on. So all these cytokines and chemokines, they incite a sudden inflammatory response in the body, which is responsible for the various symptoms of this disease. So we can see in this figure that all the cell mediators, or all the inflammatory cells rather, macrophages, dendritic cells, they produce these cell mediators, inflammatory mediators, interferons, tumor necrosis factors, interleukins, and these are responsible for the various symptoms like fever, then coagulopathies like DIC or impaired hemopoietic function, then some organ failures. For example, it can damage the liver. These mediators can also damage the kidney, and ultimately in the critical condition they can damage the whole of our body in the form of multi-organ dysfunction. So that is MODS. So that can be a terminal stage of this disease. So that is how the virus gains entry into our body, and then can affect in this manner. Now, symptomatology. So ICMR initially had proposed that the list of symptoms, where they divided it into the common symptoms, the less common, and the serious symptoms. So we can see here the most common symptoms, they are the fever, dry cough, and tiredness. So if a patient is coming with any of these symptoms, then we should be highly suspective of this coronavirus, especially during this period. The less common symptoms, they can be aches and pains, they can be sore throat, it can be diarrhea, conjunctivitis, headache, anosmia, and ageusia, that is loss of sense of smell, anosmia, and ageusia, that is loss of sense of taste, and then skin rash. So these can be the less common symptoms. And some symptoms are serious symptoms like dyspnea, it can be chest pain, loss of speech, or loss of movement. So these are the serious symptoms. Now here one point we can notice that the ENT symptoms, they are as such not very common in the patients who come with who are suspected of having this disease. Rather, the fever, dry cough, and tiredness, they are more common. So similarly, Mr. Dr. Anwar et al., they did a study, or they did a systematic review rather, and they found that the most common symptoms in patients with coronavirus disease, they did a study of around 1700 patients, and they found that fever was the most common symptom, followed by cough, then malaise or fatigue, then expectoration, dyspnea, myalgia, diarrhea, in that order. So here also we can see that per the ICMR report, the fever, cough, and malaise, or tiredness or fatigue, they are very common symptoms of COVID disease. In the same study, they also studied the ENT symptoms. So here we can see that among the ENT symptoms, sore throat, headache, then smell affection, pharyngeal erythema, nasal congestion, nasal obstruction, runny nose or rhinorrhea, URTI, that is upper respiratory tract infection, and tonsillar enlargement. So these were seen in these frequencies, the most common being sore throat, headache, and smell affection. If we compare the ENT and the non-ENT symptoms, so we can see that the ENT symptoms as such, they are very significantly less as compared to the non-ENT symptoms. Okay, but here I will especially want to talk about the two ENT symptoms, which though are present in less frequency, but they can be highly suspicious of coronavirus, and the recent evidence has shown it. So before that, Dr. Mohan Bansal sir also, way back in May 2020, he also reviewed the symptomatology in the literature, and he also came up with a very interesting classification. So he classified the symptoms as general symptoms, that is fever, fatigue, myalgia, loss of appetite, or the patient may present with respiratory symptoms like cough and breathlessness. Then ENT symptoms, he has further divided into non-specific and specific. So non-specific means the nasal congestion, the nasal discharge, sore throat, facial pain. So these are those symptoms which cannot be very particular about disease. So they can be present in any viral infection. However, there are some specific symptoms which when present in isolation and are of sudden onset duration, then they should be give us a warning that the patient might be further tested to rule out COVID. And these are anosmia and hyposmia, that is loss or decreased smell. Then ageusia and hypogeusia, that is again loss of taste or decreased taste sensation. So if a patient presents in our OPD complaining of sudden loss of the smell or taste, which is otherwise unexplained, an acute onset, then we should be very suspicious. Sometimes these can be the only symptoms, and the literature has shown that these symptoms, that is anosmia and ageusia, they can be present before the respiratory symptoms. So when we are practicing in our OPDs, if patients come and specifically they complain of these symptoms, then we should be suspicious, and then we should go for further testing. Now, Agam and AA et al., they also did a systematic review on these two symptoms specifically only, and they included 8,438 patients from 13 different countries. And what they noted was they concluded that there is a high prevalence of olfactory and gustatory dysfunction among patients who are infected with coronavirus disease. And routine screening for these conditions could contribute to improved case detection in the ongoing pandemic. So they also propose that these two symptoms, they should be included as a screening criteria for the COVID disease. So that was the prevalence of these two symptoms. So important point to note here is that these two symptoms should be kept in mind whenever a patient comes to our OPD. Now the illness severity, there are various parameters by which we can divide this disease into mild, moderate, and severe. However, one notable article I found was from the Lancet Infectious Disease Journal, which was conducted in over a large cohort of population, that is around 44,000 people from China itself, where they divided the disease from mild to moderate, severe, and critical. So mild to moderate disease is the disease in which there are symptoms are mild, or if there is mild pneumonia. Severe means dyspnea is present, there is hypoxia also, or if more than 50% of the lung is involved on imaging. So that is a severe disease. And critical, which includes additionally the respiratory failure, shock, or multi-organ dysfunction. Now here we can see that maximum cases in that particular study are of mild to moderate degree of the illness. So if we focus on the treatment of these patients, then probably we can improve the recovery rates of this disease, and we can decrease the transmission of a patient from mild to severe and critical, because it is very difficult to treat severe and critical patients because we do not have any medicine or any vaccine for this disease. All the drugs which are being given, they are on trial basis only. But however, if we can control the disease at this place, that is mild to moderate, then maybe the recovery rates will improve further. So that is illness severity. Now coming on to the diagnosis of patients with COVID. So diagnosis can be either molecular diagnosis or it can be either radiological diagnosis. So we'll see what is that. Now molecular diagnosis, that is viral testing. Now mostly three common tests are being done nowadays. First is the polymerase chain reaction, or what we commonly called RT-PCR. Now it remains the gold standard to diagnose acute infection of SARS-CoV-2 because it directly detects the RNA in the sample, RNA of the virus, and it is the most sensitive and specific test, and it is the gold standard. Now another test is the rapid antigen test, which detects the specific proteins or antigens rather than the RNA virus itself. It detects the antigens on the surface of the virus, and it can identify the people who are at the peak of the infection when the virus levels in the body are very high. So advantage of this rapid antigen test is that it is very quick. It gives a very quick results in around 10 to 15 minutes. So it is a very good test for screening purpose. However, the disadvantage is that there are many false negative reports in this patient because it can detect a virus when the virus load is actually high. So when the patient is either in the initial period of the disease, that is maybe incubation period or pre-symptomatic period, or if he is convalescent, that is he is recovering from the disease. So in those cases, the virus load is low. So maybe the rapid antigen test may not detect such patients. But however, it is a very good test for rapid screening. And the ICMR now recommends that if rapid antigen test is negative and if the patient is symptomatic, then we should confirm it with a polymerase PCR test. Then the third test, molecular test, is uh, detection of the serum antibodies in the person. Now it can again diagnose both acute and remote infections, but there are two disadvantages of this antibody test. The one is that sometimes the patient may require time to develop the blood, so the test may come negative unless the antibodies are formed in the body. Secondly, it can also detect some non-specific antibodies, maybe to some other infection or other viruses which may not be specific for coronavirus. So these two are the disadvantages. So if only one test is to be done, the gold standard, it is the RT-PCR or the polymerase chain reaction test. Then another modality of diagnosing coronavirus disease as it affects the lungs commonly, it is the high resolution computed tomography of thorax, that is HRCT thorax. Now in HRCT thorax also various studies have compared the sensitivity of HRCT thorax with RT-PCR, and they have very clearly said that HRCT thorax is more sensitive than RT-PCR. So sometimes even the RT-PCR can be negative, but the patient can have coronavirus, which is detectable on HRCT thorax. So in HRCT thorax also, there is a scoring system has been developed in which the total score is 25 and each lobe of the lung. So on left side we have 2 lobes, on right we have 3. So each lobe is given a score of 5. And based on the degree of involvement of the lung, the scores are given from 1 to 5. So the total score can be 0 to 25. The less than 5% of the lungs are involved, then the score will be 1. If it is between 5 and 25%, the score will be 2. Similarly, from 26 to 49, it will be 3. 50 to 75, it will be 4, and more than 75 lung involvement, the score will be 5. So based on this score, the severity of the disease can be done. And various things are seen on HRCT scan. I won't go in detail of that, but just to name a few: ground glass opacities, then interceptal thickening, crave paving opacities, crazy paving opacities. So these are some typical findings of patients with COVID-19. So that is about the radiological diagnosis. If there is any doubt in the RT-PCR also, then HRCT thorax is a very good test to diagnose coronavirus. Now, safe practice guidelines. So again, this is an important part of my talk today, because we as ENT surgeons, we are at a higher risk as compared to other medical fraternities. The reason is that we are in more contact and in very close contact to the patients. Whether we are examining the nose, ear, or throat, we have to be very close to the patient, and that is why the chances of transmitting this virus are more with ENT surgeons. And that is why there are some guidelines which are developed by the ICMR also and the Ministry of Health and Family Welfare also, that should be taken in mind while examining our patients. So before that, we'll see that what are the different terminologies. So when we talk about quarantine, isolation, sometimes we get confused. What is quarantine? What is isolation? Now, quarantine, it means restricting activities or separating people who are not ill themselves but may have been exposed to COVID-19 patients or virus. It means that if suppose I have a history of some contact with a person who had COVID-19, but at present I am not showing any symptoms, I'm not ill. So I will be restricting my activities, I will be separating myself. That is quarantine. So we can say that quarantine is for the benefit of myself. Secondly, isolation, it means separating people who are ill. with symptoms of COVID-19 and who may be infectious. So isolation is for the ill patients. They are separated so that they do not transmit the disease. So quarantine is for the protection of ourselves. Isolation is for the prevention of transmission of the disease. So for the protection of society at a large. And then physical distancing, as we know that we have to be physically apart. So WHO recommends a distance of at least 1 meter from each other. That is social distancing, or we can say physical distancing. So these are the terminologies. Now, there are various procedures in ENT, or I would like rather say almost all surgical procedures in ENT, which are aerosol generating. That is, they generate small particles which get suspended in the air for a long time, and they can infect the ENT surgeon. So those procedures they are direct laryngoscopy, any scopy like tracheobronchoscopy or esophagoscopy, then even the peritonsillar abscess drainage, because the oral cavity has also lodges the virus. Then nasal and paranasal sinus surgeries, which includes the nasal packing or foreign body retrieval from nose, pharynx or airway. Then tracheostomy. So tracheostomy, I will like to talk somewhat in detail later on. And then powered instrumentation, for example, we are using lasers. It produces fumes. We are using drills during our master surgeries. So it can generate aerosols. In the head and neck surgery. So because we are more doing these aerosol generating procedures, then we are at a higher risk of getting infected with this disease as compared to the doctors of other branches. So there are some safe ENT practice guidelines. So I have taken some points from various organizations. Some are from the ICMR, some are from the Ministry of Health and Family Welfare. Now regarding the OPD practice, if we see, then the ICMR says that we should do the teleconsultation or telemedicine as far as possible. Now telemedicine, it can be by way of video, it can be by way of audio, and it can be by way of text messaging also. So if possible, then we should go for telemedicine or teleconsultation. If suppose it is not possible, then in the examination room or in our OPD room, there should be one patient at a time, and mostly without attendant. So as far as possible, the number of individuals should be very minimal in the OPD. Then at the OPD entry, there should be thermal screening. Now, as we saw initially, that the fever is the most common symptom presently noted in COVID. So thermal screening is a very effective method of screening patients in our OPD. Then the general measures like the use of mask, the hand hygiene, and the social distances, they are always to be kept in mind. Then ENT doctors, when we sit in the OPD, then we should always wear a level 1 PPE kit. Now, ICMR has also given the SOPs or the operating procedures for the wearing of a PPE, in which they have guided which type of PPE is to be worn at a particular place. So in OPD, they suggest to wear a level 1 PPT. Level 1 PPT includes an N95 mask, a face shield or goggles, and hand gloves. So that is level 1 PPT. Now, as far as possible, we should avoid doing any endoscopic procedures, that is either nasal endoscopy or any laryngeal examination in the OPD. We should not do it. In case we have to do it, then it should be in a separate room away from the OPD where level 2 PPE kit should be worn. Level 2 means the proper PPE, that is including coverall, gowns and aprons. Face shields, goggles, gloves, mask, coverall, gowns and aprons, everything. So that is for the endoscopy, or even if you are to take any biopsy in the OPD. But as far as possible, these endoscopies especially, they should be totally avoided, if not on an emergent basis. Then they should be avoided, and if it is to be done, do it in a separate room wearing a level 2 PPE kit. Then regarding the ward, only one patient's caretaker should be allowed, and that also he should be screened, like thermal screening, symptomatic screening. Then there should be appropriate hand washing facilities and hand hygiene facilities available in the ward. Hand sanitization facilities should be there, and such information should be displayed on the poster, so that the layman, in the local languages, so that the layman can also understand the instructions. Hand sanitization and social distancing posters must be displayed in the ward. And it is safe to distance the two beds at a distance of 2 meters. At least 2 meter distance should be there between two beds, and it is mandatory rather. And there should be separate areas for patients who are, for example, tracheostomized, because in tracheostomized patients they produce the aerosols, and those aerosols, they stay there, they can move to longer distance, and they can infect the other healthy individuals. So the tracheostomized patients, they should be kept in a separate area. So these are some of the general points that should be taken care of for our ENT wards. Then comes the OPD, which is very important. Now, the ICMR suggests that as far as possible, the non-emergency procedures should be postponed or avoided for both COVID positive as well as COVID negative patients. So, as far as possible, no procedure which is not an urgent procedure should be performed. And if the COVID-19 positive patient is, if it all to be operated for some emergency condition, then there should be a designated OT. A separate OT should be there for COVID patients which has the negative pressures. Now, this negative pressure will prevent the aerosols from spreading. So, if you have a designated OPD for COVID with negative pressures, and if there is any emergency, then you can operate on COVID-19 patients. Then though non-COVID patients, they should be screened for symptoms. If there's any history of contact with an infected person in the last 14 days, or if the patient is coming from a zone which is high containment, or a zone which has large number of infected individuals, then that is screening should be done. Preoperative examination can also be done in the form of chest X-ray, or a more preferable modality is chest CT thorax. SpO2 monitoring should be done, because by SpO2 also we can get an idea of the severity of illness. So they say that if the SpO2 is more than 94, then it is okay, or the mild disease. Then 89 to 94, they said it is a moderate disease. Less than 89, it is severe or critical disease. So SpO2 screening should also be there. Then we should know whether the patient is having any tachycardia or not. So respiratory rate should also be noted. And as far as possible, all the aerosol generating procedures, they should be done under general anesthesia and not local anesthesia. For example, tracheostomy. So I'll come to the tracheostomy part later. But those procedures should be done under general anesthesia under complete paralysis. Now, this is a flow chart for the non-emergency surgeries. So if we are planning a non-emergency surgery in the patient, so first we should admit the patient a day or two prior to the surgery, and we should isolate the patient. Now, see, the scenario nowadays is such that every patient we should consider as COVID positive by default, unless proved otherwise. So when we admit any patient, we should isolate that patient, and we should run a RT-PCR test. If the test is negative, then we can straight away go on with the surgery. However, if the COVID is a suspect or the test comes positive, then we should postpone the elective surgery for at least 7 to 14 days. And after 14 days, we can reassess the patient. And if suppose we are not able to perform test in a patient, and it is an elective procedure, then we should keep the patient in strict quarantine for 7 to 14 days. And after 14 days, if the patient is asymptomatic, then only we should operate. Now, I don't think this is a very feasible option in our settings to isolate a patient for 14 days prior to the surgery, because nowadays patients, they just come and they want to get operated, and they do not want to stay in the hospital for a long time. But then this is the protocol, or these are the guidelines which are suggested by ICMR for the protection of both the patient and the healthcare workers. And even after the post-operative period, we should discharge the patient once he is physiologically stable, and advise the patient to remain isolated for around a week, that is 5 to 7 days. So this is a flowchart we should follow for non-emergency surgeries. Now, there are some procedure-specific guidelines also. For example, head and neck malignancy. Now, it can be considered as a semi-emergent procedure. Neither it is an elective, nor it is a very urgent sometimes. So it can be considered as a semi-emergency procedure. So what are the guidelines? The surgeon should weigh the risk benefit of postponing surgery for 14 days or scheduling procedure in the COVID designated OT. Now, if any head and neck malignancy, we can think that it can be postponed, say, for some period of time, we should postpone it. Or if not, if it is an emergency, we should always do it in a COVID designated OT. Now, many patients they come with growth in the larynx. So in the pre-COVID area, we always used to do the direct laryngoscopy and we used to take the biopsy. But now ICMR says that just for the sake of biopsy, don't do direct laryngoscopy. Now FNAC, we can do FNAC if there is a neck node and we can do a radiological imaging. And based on that also we can start the treatment. But as far as possible, only for diagnostic purpose, we should avoid doing direct laryngoscopy. Then preferably we should do day care surgery with minimal reconstructive procedures. We should not do very complex, which requires a long exposure, that is surgical exposure, surgical time. And we should minimize the use of powered instruments, that is drills and laser machines. And if at all we have to do a surgery which goes on for a long time, then we should use powered air purifying respirators. So these are specific masks in which the respirators are provided, which actively filter the air of the small particles also. So these are some of the guidelines for the head and neck malignancy. Then for other otologic or PNS surgeries or skull base, again the guidelines are that as far as possible avoid at present, and if it is life or organ threatening complications are there, that is if there is an emergency, then we can do it taking all the due care in a designated OPD. And level 2 PPE is recommended for all these procedures. Now around 1 month back there were reports in the literature that in 2 patients who were COVID positive, this coronavirus has been isolated from the mastoid ear cells also. So if we think that if we are doing ear surgery, maybe we are not directly exposed to the aerosols, maybe it is less risky than the nasal or the oropharyngeal surgeries, but maybe this is not the scenario and more evidence needs to be known. So even the otological procedures, non-emergency, they should be postponed as of now. Now, after the surgery or after the OPDs, we have to disinfect the area. So the solution recommended is 1% sodium hypochlorite, which can be used as a disinfectant for cleaning and disinfection. And the contact time of this solution, it is given as 10 minutes. Our other equipments, for example, BP apparatus, thermometers, endoscopes, they should be wiped with 70% alcohol based sprit or any swab, so that 70% can be isopropyl alcohol or even ethyl alcohol also. And the endoscopes, they can alternatively be sterilized with 2% glutaldehyde, and the contact time should be 20 minutes before the same endoscope is used in another patient. So these are some important points regarding the disinfection of the surface. And finally, role of tracheostomy. Now, in the pre-COVID area, we know that when a patient was anticipated to be intubated for a long time, the best way to go was an early tracheostomy. So that was the gold standard in the pre-COVID area. But now what has happened is that whatever literature is currently available regarding tracheostomy in COVID patients, the results are very unclear. So the benefits of performing an early tracheostomy in critically ill COVID-19 patients are very unclear at present. Very minimal number of studies, they say that early tracheostomy may be beneficial, but most of the literature is not in the favor of an early tracheostomy in COVID patients. Secondly, then we should avoid tracheostomy in COVID patients or suspected patients during the periods of respiratory instability or heightened ventilator dependence. For example, if the PEEP is very high, or if the patient is not respiratory stable, his RS is not clear, or if there is any other comorbidities, then we should avoid tracheostomy because we will not be able to give additional benefit over mechanical ventilation or oral endotracheal intubation. But having said that, these are not strict guidelines. Every case has to be discussed individually by a multidisciplinary team, which consists of an intensivist, anesthesiologist, and our ENT surgeons. So, keeping the pros and cons of each individual patient in mind, a decision is to be taken that whether tracheostomy is required in this patient or not. But again, many studies have noted that after 14 days of the infection, the viral load significantly decreases in the patient's body and the chances of recovery are high, because after 14 days the patient knows, the doctors know actually that what course the prognosis of that patient will take. Either he will get out of it or he will deteriorate. And the viral load is also low. So tentatively, we can say that maybe after 14 days is a good time to do a tracheostomy in COVID patients. But again, this is not a strict guideline or a strict criteria. It has to be individualized on a patient-to-patient basis after discussing in a multidisciplinary team. If at all we have to perform a tracheostomy, then general anesthesia should always be considered. It should not be done under local anesthesia. If the intubation is not possible, then superior laryngeal nerve block is given by injecting lignocaine. It will prevent the cough also. And the lignocaine should be injected in the trachea to prevent the cough and aerosol generation. And transient apnea has to be maintained during the brief period when we just incise the trachea and put our tube inside. At that period, we should ask our anesthetist colleagues to go for transient apnea and muscle paralysis. So these are some of the things we should keep in mind if at all we have to do a tracheostomy. Other things important are closed suction system should be used and the usage should be guarded. And before that, we should always do it in a negative pressure OT chamber. And there should be a designated OT for tracheostomy of COVID patients. And at a time, only one surgery should be done. After the completion of that, it should be properly disinfected. And then another tracheostomy if required should be done. Then double lumen cupped tubes can be used, which will avoid the frequent tube change post-operatively and minimal exposure. And heat moisture exchanger. So there are small additional valve-like things which can be attached to the tracheostomy tube, which again prevent the aerosol from spreading. And if we think that the virus load is more, then on the tracheostomy tube itself, we can use a triple layer mask or even sometimes N95 masks to further contain the spread of the aerosols. So these are some of the points which we should keep in mind while we get a call for tracheostomy in a COVID patient. And finally, the treatment. So when I searched the literature regarding the treatment of COVID-19, the first thing or the first line I came to know is that there is no treatment for this disease. Okay. However, we can use certain supportive measures which are known to be very effective. So we'll discuss those. After we quantify or after we know the severity of disease, it is mild, moderate, or severe as per the combined with the clinical or symptomatic findings. Then if it is a mild disease, then the ICMR recommends that only paracetamol, that is for fever, and hydroxychloroquine is required. Now hydroxychloroquine, again, it is a very controversial drug because we do not know exactly how does it treat COVID-19. But one thing is important, that if we are prescribing hydroxychloroquine, we should always get a baseline ECG done because it is one of the drugs which is known to prolong the QTC interval. So for mild diseases, paracetamol and hydroxychloroquine can be given. Then for moderate diseases, oxygen support is given. Now oxygen support, initially we can say that 5 liters per minute oxygen is given. And again, in moderate also, there is some role of tablet hydroxychloroquine, which the dose is given as 400 milligram on the first day, followed by 200 mg for BD for 4 days. But again, after ECG assessment, then intravenous methylprednisolone or other steroids like dexamethasone, they are also known to reduce the inflammatory response. Though for a short period of time, they can be given, and they have also shown some benefits. Then unfractionated heparin or low molecular weight heparin, because we know that there are blood coagulopathies, for example, DICs associated with COVID-19.